Okay. Hello guys, welcome back today. Now this is the third class on the renal pathology. Okay. Now in this class, let's discuss about the last topics in the renal pathology. Already we have discussed about the nephrotic syndromes. In yesterday's class, we have seen about the nephritic syndromes. Okay. And nephrotic syndromes, we have seen about the minimal change disease, focal segmental glomerulosclerosis. Also, we have discussed about the conditions like membranous glomerulopathy, membranoproliferative glomerulopathy. Those are the nephrotic syndromes we have seen. And which kind of nephritic syndromes that we have seen in yesterday's class? In yesterday's class, we have discussed about post-streptococcal glomerulonephritis, Alport syndrome, IgA nephropathy, rapidly progressive glomerulonephritis. Have seen in yesterday's. Now, in this today's class, let's discuss about the remaining topics in the renal pathology. Like small topics are there which are also important for your exam. Okay, especially important. Like integrated with the medicine. These topics are going to be integrated with the medicine. And the last important thing is the renal tumors. Okay, tumors of the kidneys. So that we will do today, and let's complete the renal pathology. Having said that, now let's begin the topic which I am going to discuss now. The first topic is going to be renal papillary necrosis. The first topic is the renal papillary necrosis, sir. Look here. So what exactly is renal papillary necrosis? It's an image-based question. You can clearly see the renal papilla. These are the papillary areas of the kidney, right? You know, the renal pyramids are going to be there. For example, the renal pyramid. See, imagine this is the renal pyramid. Now, in the renal pyramid, the papillary region, the renal papilla is undergoing necrosis. So that's the renal papillary necrosis. Now, my question to you is why? Why renal papillary necrosis? Now, in this image, you know, so these are the renal pyramids. Okay, they are the renal pyramids. Now, in the renal pyramids, okay, these are the regions of papilla. You know it. These are the regions of papilla. Now, why the hell this renal papilla are undergoing necrosis? Why they are undergoing necrosis? Because look here. Now, in this diagram, you can very clearly see the outermost region, that the cortex. The cortex will be having much more blood flow. Okay, anatomically speaking, the cortical regions will be having more deeper blood flow. When you are going deep into the kidney, as you are going deep into the kidney, the blood flow to the deeper structures, especially this cortical papilla. See, even here, look, the amount of blood supply to this region will be very less. Generally, also there is very less blood going to the renal papilla. Okay. Now, because of some condition, if the blood vessels are getting blocked, so there will be further more reduction in the blood supply to that area. So what will happen? If there is further reduction in the blood supply to these areas can undergo necrosis. Okay, ischemia, hypoxia, and followed by necrosis. Okay. So what are the causes? What are the causes of this renal papillary necrosis? Very important. The mnemonic is something like sporadic. Okay, SPORADS is sporadic. Now, see, out of all this, I want you to know at least four causes of renal papillary necrosis. The renal papilla are undergoing necrosis. What are they? First, sickle cell disease. Okay, sickle cell disease. So why sickle cell disease, sir, if you ask me? So in sickle cell disease, what exactly is happening? The RBC shape is becoming sickle, okay, sickle shaped. Now, you know, if whoever, like those who ever have this sickle cell disease, is of course there is anemia, that's okay. There will be vaso-occlusion. The sickle-shaped RBCs, they cannot easily pass through the blood vessels. They cannot easily go through the blood vessels. So what they will cause? They will cause vaso-occlusive crisis, something called as a vaso-occlusion. The blood vessels are going to be blocked. So when the blood vessels are going to be blocked, what happened to the blood supply to the papilla? Already there is less blood supply. So there is further more reduction in the blood supply. So that can cause renal papillary necrosis. Okay, one thing. Next cause is usage of analgesic agents. So usage of analgesic agents. What exactly are these analgesic agents? It's the NSAIDs. It's the NSAIDs. So non-steroidal anti-inflammatory drugs, NSAIDs. Non-steroidal anti-inflammatory drugs. See, one thing about this non-steroidal anti-inflammatory drugs is what they will do, they will inhibit the cyclooxygenase pathway. When the cyclooxygenase pathway is inhibited, what happened to the prostaglandin levels? Prostaglandins goes down. Whenever prostaglandins are not there, what happened to the blood vessels? The blood vessels will undergo vasoconstriction. There is vasoconstriction, less blood flow to the kidney, less blood flow to the renal papilla, so necrosis. So analgesic nephropathy, one of the cause of renal papillary necrosis. Sickle cell disease, one of the cause of renal papillary necrosis. Next, diabetic nephropathy. Okay, so diabetic nephropathy. So why exactly diabetic nephropathy? You know, in diabetic nephropathy, we see diabetes is it's a problem of vessels, right? In diabetes, the main problem, it's not with the heart, it's not with some other thing, it's not just the sugar. Diabetes, the main problem is with the blood vessels, the vasculopathy, sir. Okay, so in diabetes, what happens? There will be non-enzymatic glycosylation of the blood vessels. Non-enzymatic glycosylation of the blood vessels. The glucose is getting deposited here in the blood vessels. So, in this condition, diabetes, what happened to the blood vessel lumen? The blood vessel lumen, the diameter of the blood vessels is going to decrease. The blood vessels are getting narrowed, stiffened. So, let's blood supply to necrosis. Okay, in diabetes, there will be non-enzymatic glycosylation of the glucose. The glucose is getting deposited over there. So, the lumen is going to decrease. When the lumen is going to decrease, less blood supply. Less blood supply means necrosis. So, this is the third cause. So, cause number 1, sickle cell disease. Cause number 2, using of drugs like NSAIDs. And cause number 3 is diabetic nephropathy. And last but not the least, it's the pyelonephritis. Okay, pyelonephritis. Pyelonephritis means what? Inflammation in the pelvis. Okay, in the renal pelvis, sir, not in the normal pelvis. Inflammation in the renal pelvis, in this area. Whenever there is infection, pyelonephritis is infection, sir. Okay, now in this area, in the renal pelvis area, there is infection followed by inflammation. The pyelonephritis, the infection to the renal pelvis leading to inflammation. So whenever there is infection and inflammation going on in that area, that can also cause damage to the renal papilla. So renal papilla, most sensitive structures, they can also undergo necrosis. So the 4 causes, just you need to know before going to the exam. The 4 causes of the renal papillary necrosis are diabetic nephropathy, or the patient who is having diabetes. Second one is analgesic usage, sickle cell patients, and infections like pyelonephritis. So these are the 4 important causes I want you to know. After this, yes, this is done. Okay, the topic of pyelonephritis is completed. Sir, not pyelonephritis, renal papillary necrosis is completed. Image based question important. So if you can remember, other causes also you can remember, like obstruction, renal vein thrombosis, okay, other infections like TB, cirrhosis. They can also, to certain degree, they can also lead to renal papillary necrosis, but not that important. 4 causes I have given. Now after this, let's discuss about acute tubular necrosis. So what exactly is happening in this acute tubular necrosis? So what exactly is happening in the acute tubular necrosis? See, the name itself is there. Acute means suddenly. There is tubular necrosis. Okay, there is necrosis of the tubular, right? Let me write here. There is a necrosis of tubular epithelial cells. Okay, especially which tubule? Proximal convoluted tubule. Okay, especially the proximal convoluted tubule. You know, right? For example, look here. You know, just by looking at it, you can say, so this is nephron. Okay, nephron, afferent arteriole, efferent arteriole, Bowman's capsule, proximal convoluted tubule. Now, see, this is the place where normally you are supposed to have what? PCT epithelial cells, the brush border, the PCT epithelial cells are supposed to be there. But what if that PCT epithelial cells are dying? Okay, the PCT epithelial cells are dying, so they are dying. Now they will die, and what they will do? All these PCT epithelial cells, now they are getting denuded. Now from that area they are getting denuded, and now see all these cells, now they are forming a cast. Now they are forming a cast. They are actually occluding the blood vessel. Now they are actually occluding the blood vessel, and that can lead to renal failure. Okay, that can lead to post-renal causes of renal failure, sir, because the nephrons are getting blocked. Okay, so now the important points which I want you to know regarding the renal tubular necrosis, sir. See, what are the causes? What are the causes of this renal tubular necrosis, right? One by one, causes. Okay, now what do you think, guys? What do you think? How many types of causes are there? There are 2 types of causes. Okay, there are 2 types of causes. 1 minute, guys. Okay, there are 2 types of causes. One is ischemic causes. Okay, one is ischemic causes. The other causes are toxins. Other causes are because of toxin mediated. So what exactly are the ischemic causes? See, there is decreased blood supply to the kidneys because of some reasons, and I will explain you what are the reasons. Because of some reason, there is decreased blood supply to the kidney. Now you know the proximal convoluted tubule, the PCT, is a highly metabolically active substance, region. It helps in absorption of 70% of the water, 70% of sodium chloride, 80% of the bicarbonates. Okay. Now, whenever there is ischemia, so the proximal convoluted tubule, yes, of course, the proximal convoluted tubule can undergo necrosis, and these PCT epithelial cells are going to become denuded and they will form the block. They will form the casts. They will form the casts. What these casts are called as I will explain you. Okay. So ischemic cause is one cause. I will explain you, like, you know, little bit why ischemia will be there, because of shock or because of hypovolemia. Okay, there are causes, and toxin mediated causes. Okay, let me write here itself. Okay, why there is ischemia? Why, what might be the reason for this ischemia? Because of hypotension. Okay, the less blood, like, you know, the less blood pressure. The blood pressure is going down. That is shock, sir. Almost shock. During shock, what happened to the tissue perfusion? Tissue perfusion decreases. Shock condition, the tissue perfusion decreases, right, during shock. So one reason is hypotension. The second reasons might be sepsis. Okay, sepsis. During sepsis also, the perfusion, there will be, sepsis means shock will be there. There will be shock, decreased blood flow. Okay, so these are the causes of ischemia. Hypovolemia can cause ischemia, like, you know, hypotension, any cause. Now, toxin mediated cause is most important. Okay, toxin mediated cause is most important, sir. What are these toxins? Toxins like myoglobin and hemoglobin. Sir, myoglobin, it was present in the muscles. Hemoglobin, it's present in the RBCs. And why they are coming out? Because of some reason. For example, if there is a crush injury, the muscles are getting crushed because of some accident or because of, like, doing too much amount of exercise. The muscles are getting crushed, sir, damaged. The muscle fibers are getting damaged. The muscle fibers are damaged. The myoglobin, which is present inside the muscle, it's going to leak. Now, from the blood, it's going to come into the kidneys. Now, in the kidneys, whatever is myoglobin that's getting leaked, the toxic substance. Myoglobin is a nephrotoxic substance. Our hemoglobin, why do you think hemoglobin is packed inside the RBC? Why not hemoglobin is simply present inside the plasma? Why it is packed inside the RBC? Because hemoglobin is a nephrotoxic substance. Hemoglobin can kill the PCT epithelial cells. Okay, so myoglobin and hemoglobin, they act like toxins for the kidneys. Okay, they can cause. Are conditions like hyperuricemia. When you will have hyperuricemia conditions, maybe because of tumor lysis syndrome. Tumor lysis syndrome. There is a tumor, imagine there is a tumor and you are breaking the tumor. Okay, imagine there is a tumor, might be a cancer, the tumor might be a cancer. With anti-cancer drugs, you are killing the tumor. When the tumor cells, whenever they are getting killed, what happens? When the tumor cells are getting killed, cell is dying, okay. What about the nucleic acids? The nucleic acids will undergo metabolism, produces the uric acid. This uric acid can actually cause the damage to the PCT epithelium. Okay, so this is hyperuricemia conditions, leaking of myoglobin, leaking of hemoglobin, and certain types of poisons like ethylene glycol. Ethylene glycol poisoning or mercury poisoning. Okay, they can also cause toxin mediated damage of acute tubular necrosis. Toxin mediated damage of acute tubular necrosis, and even certain kind of drugs. Okay, drugs like aminoglycosides, vancomycin. Okay, so these drugs can also cause nephrotoxicity. Okay, toxic effect to the. So at the end of the day, the point what I want you to know is, because of some reason, PCT epithelial cells are dying. Now these PCT epithelial cells, they will denude from there. Now these PCT epithelial cells, they will try to come out through this nephron. While they are coming out through this nephron, okay, these PCT epithelial cells, they form a cast. So in the urine, what you will see is, brown. These are not RBC casts. These are not WBC casts. These are not lipid casts. These are brown, muddy casts. Okay, so these are brown, muddy casts. 1 minute, guys. So these casts are going to be called as brown, muddy casts or dirty casts. Okay, brown muddy casts are going to be seen in this condition. Okay, so these are some important points which I want you to know. The complication because of this condition is, okay, the complication because of this condition is renal failure, post renal failure, post renal failure. So why I am calling it as a post renal failure? Because there is no problem in the blood supply. Blood is normally coming to the kidneys. So it's not a prerenal clause. There is no problem in the kidney also. Okay. So post renal failure, why? Because there is a block. There is a block. Okay. So sorry, sir. Sorry, I shouldn't be calling it as a post renal failure. It's an intrarenal failure. Okay, intrarenal causes of renal failure. Sorry, just correcting my thing. The intrarenal cause, not a post renal cause. Post renal causes are because of the kidney stones. Okay, these are the intrarenal causes. Okay, that's a medicine thing totally. But anyway, intrarenal causes are renal failure. Yeah, there is some problem in the kidney. That's the acute tubular necrosis. The tubule is getting necrosed. Okay, necrotized. Cells are dying. So that will cause the renal failure. Why? Because there is a block. Now see, there is a block. Okay, so that's the problem here. Now after this, completed acute tubular necrosis, completed. Two types: ischemic causes as well as toxic causes. Toxins I have given. They are the important things which you need to know. The most important thing which you should never forget for your exam is this brown muddy cast presence in the urine. Whenever you see this word brown muddy casts, always think about the acute tubular necrosis. And also renal papillary necrosis. What are the four important causes of the renal papillary necrosis? The four causes which you should never ever forget: sickle cell disease, diabetic nephropathy, analgesic usage, and pyelonephritis. Okay, these four. Next. So the next topic which I want to discuss here is nephrolithiasis. Nephrolithiasis. So what exactly are the nephrolithiasis means? Kidney stones. You know it. Nephros means kidneys. Lithos means stones. So nephrolithiasis means kidney stones. Kidney stones. Nephrolithiasis means kidney stones. Okay. Now, why kidney stones? Why exactly kidney stones? See, the kidney stones are because, actually, look here, in this table it was given. See, there are certain inhibitory factors. Okay, there are certain inhibiting factors for stone formation. Okay, always in our urine, okay, in our urine, there are certain factors always try to inhibit the stone formation. But there are certain factors which can try to form the stone. There are certain factors which inhibit the stone formation. There are certain factors which always promote the stone formation. If there is an imbalance, between these factors, promoting factors and inhibiting factors, if there is an imbalance, means less amount of inhibiting factors and more amount of promoting factors, if there is such an imbalance, so that can cause kidney. Now important points which I want you to know are, see, they go citrate, very very important, citrate, magnesium, pyrophosphate. Okay, see, these inorganic substances, citrate, magnesium, pyrophosphate, these inorganic substances are present in the urine, they will always try to inhibit the stone formation. Okay, and there are certain organic things also. Okay, organic things which can inhibit the stone formation also, but the most important point which I want you to know is citrate. Okay, but who precipitates or who promotes the stone formation? It's all the ions, sodium stone, sorry, the calcium phosphate stones, calcium oxalate stones. So presence of more calcium in the urine, sodium, oxalate, urates, cysteine. See, these things, if you have them in excess, not in normal quantities, if you have them in excess, so these sodium, calcium, oxalate, citrate, okay, cysteine, they can form the stone. So what is the important point which I want you to know? There is an imbalance between the promoting factors and inhibiting factors. That can lead to stone formation. Okay, that can lead to stone formation. Now, if you have nephrolithiasis, okay, right now imagine I am having a kidney stone. What are the clinical features that are going to be there? What are the clinical features, sir? The clinical feature number 1 is going to be abdominal pain. abdominal pain. The patient is going to have abdominal pain. That's the most common thing. Okay, abdominal pain. Second one, because of the stone, there may be, not every time, there is a chance that the patient even can have hematuria. Okay, the patient can have hematuria. The patient can have renal colic. Third one, renal colic. Guys, the patient can have renal colic. Why renal colic? Because the stone, it's not going to be staying in one single place. It's not going to be static. It's going to move. The stone from renal pelvis, it can come into the ureter, the proximal ureter. From there, it can go into the middle of the ureter, distal end of the ureter. From there, it can go into the bladder, and it can move into the urethra. See, while the stone is moving, it can actually cause pain, sir. It can actually cause pain. Okay, that's the renal colic. Okay, so abdominal pain is going to be there, hematuria, renal colic can be present. So because of, see, this kidney stone, you know, the pain is going to radiate. Okay, the stone pain, let me write here. So the stone pain, it radiates. It radiates to where? See, the stone pain is going to radiate to the testis. Males. Males, it looks like a testicular pain, but it's not. It's a referred pain. It's a referred pain. Okay, so due to the presence of the stone, can lead to a referred pain in the testis. Okay, referred pain in the testis. In females, it's the labia majora. Okay, in females, the pain radiation is going to be seen towards the labia majora in females. Okay, that's the one thing which I want you to know. And even the pain can radiate to iliac fossa. The pain can radiate to groin region. So it depends on where the stone is present. Whether the stone is present in the renal pelvis, whether the stone is present in the proximal ureter, middle of the ureter, or at the end of the ureter. So depends on the place, the pain radiation can be different. That you can study in your medicine. Depends on the place where the stone is present, the person can experience pain in different regions. Okay. So the important points are that patient who is having nephrolithiasis can have abdominal pain, hematuria, renal colic. Okay. So after this, let's discuss about the types of stones. Okay, the types of stones. The first type of stone that I am going to discuss here is calcium oxalate stones. Calcium oxalate stones. See, the name itself is there. The stone in the kidney which is made up of the calcium oxalate. Calcium and oxalates are the most common kidney stones. The most common kidney stones. They are the most common kidney stones. Now, can you see them on X-ray? Yes, they can be seen on X-ray. So they are radio opaque because certain stones cannot be seen on X-ray. So these are visible on the X-ray. These are visible on the X-ray. Okay. So what is the most common cause? What is the most common cause? Which people can get this? Calcium oxalate stones. The most common cause for this type of stone is, we don't know, idiopathic, hyper, calciuria. Idiopathic hypercalciuria. Idiopathic means we don't know why, but there is hypercalciuria. More and more calcium is going out in the urine. The blood levels of calcium is normal, but more amount of calcium is going out in the urine because of some reason. We don't know. As more and more calcium is getting into the urine, now in the urine the calcium will precipitate and calcium is going to form a stone. Simple. So the most common cause is idiopathic. The other causes can include hyperparathyroidism, okay, hyperparathyroidism. Why? The more amount of parathyroid hormone increases the blood calcium level. Simple. Hyperparathyroidism. More parathyroid hormone means more amount of calcium levels. Okay. See, this is the oxalate stones, right? Maybe conditions like hyperoxaluria. Okay. Lots and lots of oxalates are going out in the urine. Important point which I want you to know is very important. These calcium oxalate stones are seen after some poisoning, sir. Which poisoning? Ethylene glycol poisoning. See, you will study this again in medicine as well as forensic also. This topic will come. Okay. So whenever whoever have this ethylene glycol poisoning, they can develop this renal stones, kidney stones, renal stones seen in ethylene glycol poisoning. Now, after this, what else you should know? Go guys here. What exactly is Randall's block? Randall's block, see here, stone. It's the first stage in the formation of the stones. The starting point, Randall's block. Randall's block. What exactly? It's a starting point for stone. Starting point for the especially calcium oxalate stones. Okay, so which is seen in the tip of the papilla. See, this is the tip of the papilla. That's it. Okay, it's seen. Randall's block seen. Tip of renal papilla. So all the calcium is getting precipitated, and that's the first place where you can have the stone. Okay, so that's the Randall's plaque made up of the calcium oxalate stone. Right now, imagine there is this one person who is having hypercalciuria, or in these persons, you just the patient who is having a kidney stone, most probably the calcium stone is made up of the calcium oxalate or calcium phosphate kind of stone. Now, if you take his urine, and in the urine you can actually look at these crystals. Okay, these are not stones, these are the crystals. So, what is this first crystal? The appearance of the calcium oxalate stones, right? Appearance of calcium oxalates in urine. Okay, there are small things. Okay, the calcium oxalate crystal. Now, the first one, see how it's looking like. It's looking like a dumbbell shape, right? Looking like a dumbbell. It's looking like a dumbbell. So, what are these? These are the calcium oxalate monohydrate crystal. Okay, the first type of crystal is called as calcium oxalate monohydrate. How the shape? The shape is going to be the calcium oxalate monohydrate crystals are going to be dumbbell shape. Okay, they are going to be in dumbbell shape. Some books mention picket shape. Okay, they are going to be dumbbell shape or picket shapes. Usually it is seen with ethylene glycol poisoning. Okay, seen with ethylene poisoning. Okay, ethylene glycol poisoning. The second type of crystals, which you can see here, see, these are also calcium oxalate crystals, but how they are looking like? So they are looking like envelope shape. They are looking like an envelope, right? You know, right? The envelope, how it looks like the Gmail envelope. Okay, so they are also looking like envelope. So what are these? So these are calcium oxalate dihydrate crystal. Okay, calcium oxalate dihydrate. Calcium oxalate dihydrate crystal. Okay. So they are going to be envelope in shape. Envelope shape, some books mention as a bipyramidal shape. Okay, envelope shape, bipyramidal shape, different. So the first type of stone completed, the most common stone, that's the calcium oxalate stones completed. Okay, what is Randall's plaque? You know it. What are the causes of the calcium oxalate stones? And what are the microscopic appearance? The urine microscopic appearance. Calcium oxalate monohydrate crystals are going to look like a dumbbell. Calcium oxalate dihydrate crystals are going to look like an envelope. Okay, envelope. So what is the treatment, sir? What is the treatment? The treatment for this calcium oxalate stones is going to be the treatment with thiazide diuretics. Thiazide diuretics. Because I hope you already know. So thiazide diuretics, what they will do? Thiazides increases the calcium reabsorption into the body. Thiazides decrease calcium excretion. Whenever the calcium is not getting excreted, the stone formation also automatically decrease. Okay? So usually these patients will be having recurrent stone formation again and again. So these patients will be kept on thiazide diuretics. That thiazide diuretics, what they will do? They increases the calcium reabsorption back into the body, so that less calcium is going out in the urine. Less calcium means less amount of stone formations. Simple, as simple as that. Okay. Now, after this, the second type of stone that I want you to know, look here. So, these stones, see how big they are. So, this is not, it's looking like a ginger piece, right? But this is not a ginger piece, it's a big stone, sir. It's big stone, it's looking like a horn, stag horn. Like, you know stags, right? The deers kind of thing. So, how their horns are going to be? Horns, like branched horns, the antler horns. Okay. So, these horns are also very big. Okay, they are going to be called as staghorn calculi. Okay, staghorn calculi. So, let me write one by one point. So, these stones are also called as white stones or triple stones. White triple stones. They are made up of ammonium, magnesium, and phosphate. They are made up of what? Which materials? Not calcium oxalate. They are not made up of the calcium oxalate. They are made up of ammonium, magnesium, phosphate. AMP. Okay, that's why triple stone. You can also call it as a triple phosphate stone. True white stone, triple phosphate stone, AMP stones. You can call them with any name. Okay, made up of magnesium, ammonium, and phosphate. See, these stones, they are very big. Okay, they are very big. What they will do is they can even cause the damage. They will cause damage to renal pelvis. They will cause damage to the renal pelvis. Now, important point is, they are associated with what? So, this type of struvite stones seen in which people? In every people? In general public? No. So, these stones are going to be associated with infections. Okay. Sir, which infections? Sir, infection with which organism? Proteus. Proteus infection. Klebsiella. Klebsiella infection. Proteus infection. Klebsiella infection. Okay. Staphylococcus saprophyticus infection. Especially for your exams, they will ask you this. Proteus infection. Proteus infection. Next, Klebsiella infection. Okay. So, whenever you are having the infection with these organisms, whenever you have infection with these organisms, do you know what happens? The urine is going to become alkaline. The urine is going to become alkaline, sir. It is the alkaline environment which favors the stone formation. Which stone formation? The AMP stone formation. It's the alkaline environment. Very, very important. Normally, for the formation of a stone, you need to have the acidic environment. But for the formation of this AMP stone, you need to have the urine alkalization of the alkaline environment. Okay. So, pH is going to be more pH. Alkaline environment is alkaline environment. So, it's associated with infections like Proteus and Klebsiella, which will cause urine alkalization. Now, if you look at the urine examination, what you will see? Look here, how the crystals are going to look like. So, the crystals, they are looking like a coffin. Okay. See, in the Western countries, the people after the death, they will be kept in the coffin, right? So, it's a coffin lid, sir. So, this is a coffin lid. It's looking like a coffin. Okay. So, coffin lid appearance. Coffin lid appearance. So, what you will see is in the urine, the coffin lid appearance of the crystals can be seen, the AMP crystals. So, these are the important points which I want you to know, sir. So, these stones are also completed. Provide stones, big stones, made up of ammonium, magnesium, and phosphate. Seen in the infections because of the Proteus and Klebsiella, urine alkalization, coffin lid appearance is going to be seen. Next, after this, the third type of stone, calcium oxalate stones, calcium oxalate. Second time, AMP stones completed. The third type of stones which I want to discuss here are acid stone. Uric acid, the uric acid stone. So, the uric acid stone, they are the softest stone. Okay, they are the softest stones. The uric acid stones are the softest stones. And this uric acid stones, see uric acid stones, they are going to be formed in acidic pH. Not only them, most of the stones form in the acidic pH, sir. Okay, so it's seen in which conditions? Okay, associated with which condition? See, the name itself is there, it's the uric acid stone. So, wherever the uric acid levels increases, whenever the uric acid levels increases, whenever the uric acid levels increases, then you can have this stone. Now, question is, when the uric acid levels are going to be increased, in which conditions? The tumor lysis syndrome. Lysis syndrome. Okay. So, in tumor lysis syndrome, I have explained you, when you are targeting the cancer, you are targeting the cancer with the anti-cancer drugs. The anti-cancer drugs are going to go and kill the cancer. When the cancerous cells are dying, even cancerous cells are cells. Even they have the nucleus, they have the DNA, they have the nucleic acid materials. Then when the cancerous cells are dying very rapidly, the nucleus is also dying. The nuclear materials, the nucleic acid is getting metabolized, degraded. What is the degraded product of the nucleic acid? Uric acid. So suddenly uric acid levels increase. So in tumor lysis syndrome, tumor breakdown syndrome, if we are breaking down the tumor, the uric acid levels increases. Not only this, in this condition, there is a condition called as Lichtenheim syndrome. Lichtenheim syndrome. Even with this Lichtenheim syndrome, the uric acid levels are going to be elevated. Okay, the uric acid levels are going to be elevated, sir. The important point about this uric acid stones is one more thing. They are radiolucent stones. They are radiolucent stones, which means you cannot see the stones. Okay, this uric acid stones cannot be seen on X-rays. You cannot see it on X-ray because they are radiolucent. Okay, they are radiolucent. So these are some important points. Uric acid stones, softest stones. These stones will come in multiple shapes. Here in the urine also, you can have different types of crystals. They are going to be formed in the acidic pH. They are radiolucent stones associated with the conditions like tumor lysis syndrome as well as Lichtenheim. Now, the last conditions, last type of stone, Cysteine stones. The fourth type of stone is Cysteine stones. So, Cysteine stones are seen in which conditions? Cysteine stones are associated with cystinuria, so cystinuria. There is a condition called as cystinuria. Sir, what exactly is this cystinuria if you ask me? The cystinuria is an autosomal recessive disorder. It's an autosomal recessive disorder. Where is a defect in the PCT? There is a defect in the PCT. Now, there is a defect in the PCT, sir. PCT problem. Now, normally PCT have to reabsorb the cysteine. Now, there is a defect in reabsorption of the cysteine. Okay, there is a defect in PCT right here. Reabsorption of cysteine. So, what exactly is the cysteine? You know, cysteine is an amino acids. Amino acids are freely filtered in the nephrons. Amino acids, glucose amino acids are freely filtered in the nephron. But there is this one condition which is called as cystinuria, autosomal recessive disorder, where there is a defect in the PCT to reabsorb the cysteine. The cysteine is not getting reabsorbed, so cysteine is going to be lost in the urine. So in the urine, the cysteine levels are going to be concentrated, elevated. So here, the cysteine is going to precipitate and form the stone. The cysteine stones. Important point about the cysteine stones are, the cysteine stones are the hardest stones. They are the hardest. Other stones are comparatively, other stones are softest. Yeah, one of the softest stone is the uric acid stone. Just now we have discussed. Hardest stones out of all are the cysteine stones, sir. Okay, the cysteine stones. The dibasic, like amino acid which cannot be reabsorbed in this condition. Okay. Next, so these stones are formed in which environment? All stones are going to be formed in the acidic environment only. But that AMP is specialized. Okay, AMP is something special. Alkaline environment. These are also going to be formed in the acidic environment, sir. Acidic environment. Now, those who have this cystinuria, okay, cystinuria, sir. Now, one important point is smell of their urine. You know what is the smell of their urine? It's going to be rotten egg smell. Okay, rotten egg. So those whoever have this cystinuria, they will be having rotten egg smell, sir. Okay, they will be having rotten egg smell is going to be seen. Now, under the microscopic examination of the urine, see, look at the stones, how they are going to look like. So these are the crystals. Actually, these are not the actual stone. These are the crystals. Now, it's looking like a hexagon, right? It's looking like a hexagonal shape. Okay, hexagonal. Stones are going to have hexagonal. Yeah. Next, stones are also completed the 4 types of stones that I have discussed: calcium stones, AMP stones, cysteine stones, acid stone. Now, what is this image? Cysteine stone. Okay. Now, this image, coffin lid appearance, AMP stone, or Staghorn calculi. Okay, the bigger stones. where the entire pelvis, the stone is going to occupy the entire pelvis and cause the damage to the pelvis. Okay. The next type, calcium oxalate, monohydrate, calcium oxalate, dihydrate. Okay, calcium stones, calcium crystals under the. Now, after the nephrolithiasis topic, the next topic I wanted to start without any further late is the renal tumors. Renal tumors. The renal tumors are of two types. One is a benign tumor and the other is a malignant tumor. Benign is non-cancerous, malignant is cancerous. So, what are the benign tumors that can come to your kidneys? Benign tumors, just a tumor, not a cancer. The first benign tumor I want to discuss here is angiolipoma. Angiolipoma. The name itself is there. Angio means blood vessel, myo, muscles, lipoma, fats. So, this is a tumor. Okay, this is a tumor. It's made up of what? Mainly fats, sir. That's why it's yellow in color. Angiomyolipoma. Made up of the fats. That's why yellow in color. Okay. So, that's why under microscopy also you can see lot of these white spaces. What are these white spaces, sir? These white spaces are what? These white spaces are nothing but the fats. Okay. Now, what are these? These are the blood vessels. Okay, what are these? These are the blood vessels. Angio blood vessels. Okay, angiomyolipoma. Okay, blood vessels are going to be seen. Muscles are going to be seen in the tumor. The muscle tissue is going to be seen as well as the fats. The adipose tissue is also going to be seen, sir. Angiomyolipoma. Okay. Now, important point is, sir, this angiolipoma, who will have this? Associated with tuberosclerosis. Okay, tuberosclerosis. Now, even in genetics, we have discussed about this, the TSC1 gene, TSC2 gene mutation. Okay, tuberin, hamartin proteins are going to be defective. But anyway, sir, this angiomyolipoma is associated with what? Associated with tuberosclerosis. Okay, देखो here, tuberosclerosis, again it will come in your dermatology also. It will come in your derma also, tuberosclerosis, pneumonic. I don't want to go into the entire mnemonic. Here देखो A, angiomyolipoma of the kidneys. So those whoever have tuberosclerosis are going to have ash leaf spots, okay, chagrin patches, that thick leathery patches at the end of the, near the lumbar region. Okay. So I don't want to go into each and everything. Simple. Those whoever have angiomyolipoma, they are associated with tuberosclerosis. So tuberosclerosis is the one condition, which can have angiomyolipomas. Okay. Now, under histology. Okay, under histology, you know it. What will be there? Sir, under the histology, what are the things that are going to be there? Blood vessels, angio, blood vessel, that's why angio, blood vessel, myo means muscles, and adipose tissue. Okay, so angiomyolipoma, that's why angiomyolipomas. Myocytes will be there, like myocytes are muscles, blood vessels, and next, sir, after this, what else? So the second type of benign tumor, first type of benign tumor is completed, angiomyolipoma, the most common benign tumor, completed. Next, the other benign tumors which you can have is oncocytoma. So tell me, oncocytoma is a benign tumor or malignant tumor? The oncocytoma is a benign tumor, not a malignant tumor, it's not a cancer. Okay, so if you ask, what are oncocytes? What are the oncocytes? What are oncocytes? Okay, the oncocytes are nothing but the cells. Okay, the oncocytes are nothing but the cells with hyper-eosinophilic cytoplasm. Okay, so it will be hyper-eosinophilic granular cytoplasm. Okay, with the prominent mitochondria. So these are some important points which I want you to know. Oncocytoma, you are going to have oncocytes. Oncocytes, what exactly are the oncocytes? Oncocytes are nothing but the cells with a hyper-eosinophilic cytoplasm with a prominent mitochondria. Going to be. Okay, so it is associated with what? Okay, it's associated with. Okay, in which what are the conditions which can lead to this oncocytoma? So loss of chromosome number 1. Okay, loss, sir, gone. Chromosome number 1 gone, sir. Deletion of chromosome number 1 can lead to this oncocytoma. Now, if you look at the tumor, see, you can very easily identify whenever you are shown with a tumor. See, this is the tumor. Kidney. First of all, it's a kidney. On with the tumor. Sir, how the tumor is? Yellow, sir. Whenever you are seeing yellow color tumor, you can simply say, sir, this is angiomyolipoma. Lipoma. Okay, fat tumor. Now, the same way, look here. Again, this is the kidney. And what you are seeing here, sir, here is a tumor. Here there is a tumor present. Now, even in this tumor, look, in the center of the tumor, there is white color appearance. Okay, there is this white color appearance. So, what exactly is this, sir? This is called as a stellate scar. There is a scar in the middle of the tumor. Okay, even here, look, sir, here is a tumor. In the center of the tumor, are you able to appreciate this white scar? So, this is called a stellate scar. Everywhere, sir, here also. Dekho. So, whenever you see such a stellate scar, this word, keyword, is oncocytoma. Okay, here also, dekho. But have you appreciated one thing? What is the color of the tumor? The color of the tumor is going to be brown. Okay, there is a tan brown color, sir. There is a tan brown color here also. There is a brown color tumor. The tumor is going to be brown color. So, in the brown color tumor, there is a stellate scar in the middle. Okay, there is tumor is going to be tan brown in color. In the center, what you will see is stellate scar. Stellate scar. A stellate scar is going to be seen in the center. Okay, so that is the one important point I want you to know. So, these are what? These are oncocytes. Okay, all these are the oncocytes. See, look at the cytoplasm. How the cytoplasm is? It's a granular cytoplasm, hypereosinophilic granular cytoplasm with lots and lots of mitochondria. Oncocytes are nothing but the cells with a lot of mitochondria. Oncocytes with a lot of mitochondria. Okay, so done. See, dekho, oncocytoma. Okay, mahogany brown tumor or the tan brown color of the tumor with the stellate scar in the middle. Stellate scar in the middle. So done. The benign tumors are completed. Now, let's directly jump into the topic of malignant tumors. Malignant tumors. The first malignant tumor that I am discussing here is the renal cell carcinoma RCC, which is also called as MCQ, which is also called as hypernephroma or Graves tumor. Graves tumor or hypernephroma or renal cell carcinoma. It is going to be seen in young people or old people? Old people. Okay, 60, 70 years. Seen in age group of 60 to 70 years. Going to be seen in males or females, sir, mainly? Going to be seen mainly in the males. Which sex is going to be most commonly affected? Males. That okay, males are going to be affected most commonly than the females. So, okay, it's a malignant tumor, which means a cancer. Okay, which means a cancer. There is a cancer arising from which cells? It's a cancer, okay, but cancer of which cells? The cancer of PCT epithelial. The cancer of PCT, or I should say renal tubular cells. Renal tubular. Okay, you know the epithelial cells, right? Imagine this is the proximal convoluted tubule. There will be cells, PCT epithelial cells. Now that PCT epithelial cell is getting a tumor. That PCT epithelial cell is getting a tumor. There is a tumor of renal tubular cells, and most commonly, see, the tumor is going to be in the upper poles of the kidney. That's very important. So, upper poles. If they specifically mention, upper poles of the kidneys are getting affected. RCC, renal cell carcinoma. Upper poles of kidneys are affected. Okay, upper poles of the kidneys are going to be most commonly affected. Now, if I imagine that I am the patient who is having, there is this one patient, sir, who is having this renal cell carcinoma. What are the triad of symptoms that are going to be seen? Okay, triad of symptoms, sir. First triad of the first symptom is going to be hematuria. Okay, there's going to be hematuria. That's the most common. The blood coming out in the urine because of this tumor. Hematuria is going to be seen. Second one, abdominal pain. Okay, abdominal pain is going to be seen. Not just abdominal pain, because of this, there is a tumor going, right? There is a tumor growing. So, there will be abdominal mass. The abdominal mass can be felt on palpation. Okay. So, hematuria, abdominal pain and abdominal mass. Hematuria, abdominal pain and abdominal mass. These are the three triad of symptoms which we seen. It's a cancerous condition. So, anyway, weight loss, nausea, vomitings, okay, fever, malaise, all these things will be generally seen. But triad of symptoms is important for your exam. Hematuria, abdominal pain and abdominal mass. Along with that, fever, cachexia, weight loss, nausea, vomitings, okay, they can be seen. Now, what are the risk factors to get this renal cell carcinoma? What are the risk factors, sir? Sporadic, 90% of the cases. Sporadic. Sporadic. Means just like that in the population, it can happen in anyone. Okay, sporadic. 90% of the cases do not have any risk factors. They simply will come and they are having renal cell carcinoma. There is no risk factor. Okay, they are not having any risk factors. Generally sporadic. It can come in anyone. 90% of the cases. Okay, but what are the risk factors? Now I am talking about the risk factors. That is tobacco. Tobacco, that is the smoking. Are those persons who are exposed to asbestos exposure. Okay, so tobacco smoking, asbestos, are those persons who are having hypertension. Hypertension can be a risk factor. That person who is having, like, obesity. Okay, obesity can be seen in sickle cell anemia. Like, sickle cell anemia can be a risk factor. Okay, that person who is having hyperestrogenemia. Hyperestrogenemia, high levels of estrogens in the body. So tobacco, asbestosis, hypertension, obesity, sickle cell anemia, hyperestrogenemia, all these can be a factor. Okay, all these can be a risk factor, but 90% of the cases, the majority of the cases, there is no such risk factor. It can happen in anyone. 90% of the cases are sporadic in nature. Sporadic in nature. Okay. Now, after this, the next important point which I want you to know is that this renal cell carcinoma can also be familial. Can also be familial, means coming in the families. So, familial variants of the renal cell carcinoma. Now, in the familial variants, not the one kidney is going to be affected, both the kidneys are going to be affected. Okay, in sporadic variant, unilateral involvement. Okay, sporadic, it's a unilateral involvement. But if you are having certain familial syndromes, they are coming from within the family, they are going to be bilateral. Okay, means some genetic involvement is there. So, what are these syndromes? If you are having a syndrome called as a VHL syndrome, von Hippel-Lindau syndrome, Okay, so in this von Hippel-Lindau syndrome, the patient is going to have a triad of cancers. Okay, 3 types of cancers mainly. Okay, because of the deletion of chromosome number 3p, the chromosome number 3p is gone. Now, what are the triad of cancers that are going to be seen? It's a renal cell carcinoma, one. Next one, pheochromocytoma. Okay, these patients can develop the pheochromocytoma, as well as patients can develop hemangioblastoma, cerebellar hemangioblastoma. Cerebellar hemangioblastoma. So, von Hippel-Lindau syndrome, there is the deletion of chromosome number 3p. 3 types of cancers can be seen. First cancer is renal cell carcinoma, pheochromocytoma, and cerebellar hemangio. Okay, so the same thing, sir. Here also, von Hippel-Lindau syndrome. The patient can have multiple tumors. One such a tumor is renal cell carcinoma. Okay, he can have multiple tumors, sir. Multiple tumors. The most important tumors I have written over here. The 3 important tumors: renal cell carcinoma, pheochromocytoma, as well as cerebellar hemangioblastoma. But they can develop multiple tumors. The cerebellar hemangiomas. Okay, pheochromocytomas. Okay, this is the familial von Hippel-Lindau syndrome, deletion of chromosome number 3p, can cause bilateral renal cell carcinomas. So, okay, so the other familial variants, which I am discussing here, is hereditary. See, in the name itself, it's hereditary, coming in the families. Leiomyomatosis with bilateral renal cell carcinomas. It's one single thing. Hereditary leiomyomatosis with the bilateral renal cell carcinoma. So, what is this condition, sir? Condition, there is a mutation of a gene. Then here, what is the gene mutation? VHL, von Hippel-Lindau syndrome, chromosome number 3p, gone. Now, why this condition, hereditary leiomyomatosis with bilateral renal cell carcinoma, is because of a mutation of fumarate hydratase. Okay, the gene which is mutated is fumarate hydratase, gene mutation on, let me write the full form, fumarate hydratase, gene mutation, fumarate hydratase, gene mutation on chromosome number 1. So those whoever have this hereditary leiomyomatosis with the bilateral renal cell carcinoma, they are going to have which involvement, sir? In the name itself, it's there. Dekho. Hereditary leiomyomatosis. Okay, leiomyomas in the uterus, leiomyomas, sir. The fibroids, leiomyomas. Okay, and look here. See the person whoever having this hereditary leiomyomatosis with bilateral renal cell carcinoma, they are having cutaneous involvement, cutaneous leiomyomas. Okay, small kind of things. And type 2 renal papillary cell renal cell carcinoma. See, renal cell carcinoma, you know it, but there are other variants also. In renal cell carcinoma, I will talk about the different variants: clear cell carcinoma, okay, papillary carcinoma. Different variants are there that I will discuss. Okay, so cutaneous leiomyomas can be seen. The second one is renal cell carcinoma, papillary type of renal cell carcinoma, and the third one is uterine leiomyomas, or the uterine fibroids are going to be seen. So tell me, what is the second familial condition that is associated with the development of renal cell carcinoma or the kidney cancer? Is hereditary leiomyomatosis with bilateral renal cell carcinoma. First one is von Hippel-Lindau syndrome. Chromosome number 3p deletion. So done. Next, the third familial syndrome. This is the second familial syndrome completed. The third familial syndrome, which I want you to know, is called as BRIT. Okay, the Bitt-Hogg-Dubé syndrome. Bitt-Hogg-Dubé syndrome, sir. So what exactly, if you ask me what is this Bitt-Hogg-Dubé syndrome, sir? Here also that fumarate hydratase gene mutation, same fumarate hydratase gene mutation, and one more gene mutation, that is BHD gene mutation. Okay, BHD gene mutation. So BHD means Bitt-Hogg-Dubé. Okay, so Bitt-Hogg-Dubé gene mutation, fumarate hydratase gene mutation on chromosome number 1. So whoever developed this Bitt-Hogg-Dubé syndrome, they will be having three things. They will be having three types of cancers. What are the three types of cancers? Actually, two cancers. So one is a skin cancer, right? One is a skin cancer. They will develop the skin cancer. Second one is renal cell carcinoma, our thing, the renal cell carcinoma. And the third one is these patients we usually have pulmonary cysts. Thank you. The patient is going to develop the pulmonary cyst, renal cell carcinoma, and the skin cancer. At the end of the day, what are the three familial syndromes which can be associated with renal cell carcinoma? Von Hippel-Lindau syndrome, hereditary leiomyomatosis with the bilateral renal cell carcinoma, and third one is BHD, Bitt-Hogg-Dubé syndrome. In which condition the patient is going to have leiomyomas? Second one, hereditary leiomyomatosis, uterine fibroids. In which condition the patient is going to have pulmonary cyst, Bitt-Hogg-Dubé syndrome. In which condition the patient is going to have cerebellar hemangioblastomas, von Hippel-Lindau syndrome, chromosome number 3p mutation. Sir, in these two conditions, hereditary leiomyomatosis as well as the Bitt-Hogg-Dubé syndrome, the same gene mutation, it's a fumarate hydratase gene mutation. Okay, fumarate hydratase gene mutation is going to be seen, sir. Now, after this, what else? What else, sir? See, this renal cell carcinoma, is there, right? It is further classified, sir. Okay, there is classification. Okay. Histologically, classification of renal cell carcinoma. That's a classification. Histological classification under the microscope, how it's looking like. What are the different classification? Like, what are the different types? One is clear cell carcinoma. Clear cell type of renal cell carcinoma. The clear cell type of renal cell carcinoma, that's the most common type. Okay, that's the most common type, sir. Right here. The second type is the papillary carcinoma. So where we have seen this word papillary carcinoma, already we have seen, dekho here, the papillary RCC is seen in papillary type of renal cell carcinoma is associated with hereditary leiomyomatosis with bilateral renal cell carcinoma. Okay, hereditary leiomyomatosis with renal cell carcinoma, bilateral renal cell carcinoma. Okay, you are going to have papillary variants. Okay, done. So clear cell carcinoma completed. Papillary cell. Next, chromophobe. The chromophobe variant can be seen. Next, Bellini. Okay, next type is Bellini duct variant. Okay, Bellini duct variant. Next, medullary carcinoma. Okay, there are different types, histological. All these are the histological variants. But I don't want you to go through each and everything. At least few things are important, sir. Clear cell carcinoma is important, papillary important, chromophobe important. Okay, the first three are very important. Okay, all these are what? These are the histological variants of the renal cell carcinoma. Okay, and don't forget one thing: all RCCs, all these RCCs, all these are adenocarcinomas. Okay, all the renal cell carcinomas are adenocarcinomas. All the subtypes, these are all the subtypes of renal cell carcinoma, all are adenocarcinomas. Okay, that's the one point I want you to know. Having said that, now let's directly discuss about the clear cell cancer. Clear cell cancer. First, let's discuss about the clear cell carcinoma. Look here. Why we are calling it as a clear cell carcinoma? You can know it. See how the cells are looking like. This is a tumor. You have taken the biopsy from a tumor, and how the cells are looking like. They are absolutely clear, right? Clear. The cytoplasm is clear. So that's why it is called as a clear cell carcinoma. So important points one by one. The most common type. Okay, it's arising from where? Arises from proximal convoluted tubule. It arises from, it's not arising from the distal convoluted tubule, it's not arising from the collecting ducts, it arises from the proximal convoluted tubule. Now associated with what, sir? Associated with von Hippel-Lindau syndrome. So those whoever have this von Hippel-Lindau syndrome, yes, they will develop the renal cell carcinoma, but which type of renal cell carcinoma? Clear cell carcinoma. Okay, clear cell carcinoma associated with von Hippel-Lindau syndrome, sir. Okay, so usually this is, see, usually this clear cell carcinoma, it's the most common type. It's the most common type out of all. It's the most common. Okay. Now, having said that, now, sir, I hope you can understand. Based on the histology, you can say it's a clear cells, clear cells. Now based on the histology, just tell me what it's looking like. So now, the histology, it's not showing the clear cells, but rather what's more prominent here? More prominent thing is you can see the papilla. Now there are finger-like projections everywhere. Here they go. It's a finger-like projection. It's a finger-like projection. Everywhere there are finger-like projections. Okay. So finger-like means what? Papillary. They are like papillae. Okay, finger-like. So this is papillary cell carcinoma. Papillary cell carcinoma, where we have discussed. Sir, papillary cell carcinoma, they are associated with. Okay, papillary cell carcinomas, they are associated with what? Hereditary leiomyomatosis with bilateral renal cell cancer. There, sir. Okay, so right here, papillary cancer, papillae are present. Papillae are present. Papillae are going to be present. Now, from where this cancer is arising? From the PCT, a loop of Henle, or from DCT or collecting ducts? Cancer arises from which cells, sir? Again, here also PCT epithelial cells when compared to the DCT. Okay, even clear cell also from PCT, papillary cell also from PCT. Okay, next, this is the one type of cancer. Usually, I hope you already know this. That person who is having completely on the dialysis. So this dialysis associated patients, okay, these dialysis associated patients, they will develop the cancers. In the future, they will develop the cancer. Okay. So which type of cancer? See, this type of cancer. So that patient who is going to the dialysis regularly, now that patients will develop the cancers. Which type of cancer? Which type of kidney cancer? This type. Okay, associated with dialysis, right? It's associated, this papillary cancer is associated with dialysis. Dialysis associated cystic disease. Okay, so a patient who is going to the dialysis have developed the dialysis associated cystic disease that can turn into papillary cell carcinoma. Okay, papillary cell carcinoma, sir. Okay, sir, in these patients, okay, papillary cell carcinoma, sir, what are the gene mutations which can lead to this type of cancer? It's a MET proto-oncogene mutation. MCQ, MET proto-oncogene mutation. The MET proto-oncogene mutation is seen in these patients. MET proto-oncogene mutations are seen in this patient. So these are some important points which I want you to know. The next type of tumor, the malignant tumor. Okay, clear cell completed, papillary cell completed. The next type, it is called as chromophobe carcinoma. Chromophobe variant. Look at the cells. Now, some of the students will confuse. Sir, it's also looking like clear cells. Okay, there are no papilla, okay, but it's also looking like clear cells. See, these are not clear cells, sir. Okay, these are not clear cells. See, there is fine granular cytoplasm. There is fine granular cytoplasm. Still cytoplasm is there. Yes, cytoplasm is there. But in clear cell type, let me show you. See how here? In clear cell type, there is no cytoplasm. It's a clear cytoplasm. But look here. There. Cytoplasm is there. Okay, the granular cytoplasm is seen. Okay. Here, how it is looking like, sir? Class 11th and 12th. I hope you have seen the leaf under the microscope. Now it's looking like leaf kind of arrangement is seen. So now let's write one by one important points about the chromophobe carcinoma. This chromophobe carcinoma, it's associated with, right? Very, very important point, associated with BHD syndrome. Now students start to think, sir, BHD means Brit-Hog-Dubé syndrome? Yes, exactly. So that person who is having Brit-Hog-Dubé syndrome will develop renal cell carcinoma. But which type of renal cell carcinoma? Chromophobe variant. Okay. One important good point about this chromophobe variant is, see, I have said you, it's looking like a leaf. The architecture is looking like a plant cell. A plant cell. So plants are very good, right? Very good for the environment. Best prognosis. This type of cancer is going to show best prognosis. This type of the cancer is going to show the best prognosis. Next, what else? It's going to look like a plant cell. Plant cell appearance. A plant cell appearance is going to be seen. A plant cell appearance is going to be seen. Now, it's like this one type of cancer, the chromophobe variant, it stains with stains with Hales colloidal. Okay, it stains with Hales colloidal iron. It's a stain, sir. It's a stain. So देखो here, the coming blue. Okay, this blue color stain is Hales colloidal blue. Now this Hales colloidal blue is going to be positive. It's going to be positive in this chromophobe tumors. It's going to be positive in chromophobe tumors, but it's negative in other tumors, sir. It's negative in other tumors. So what are the important points? One important point I forgot. So they are arising from where? This chromophobe carcinoma, it arises from collecting ducts. Arises from where? It arises from collecting ducts. Check you. Okay, not the PCT, it arises from the collecting ducts. So with this, chromophobe variant is also completed. The three important things: clear cell carcinoma, papillary carcinoma, as well as chromophobe variant. Chromophobe variant, collecting ducts, plant cell like, positive with Hales colloidal iron. It's going to show best prognosis. It's going to show best prognosis associated with Brit-Hog-Dubé syndrome. Okay, associated with the Brit-Hog-Dubé syndrome, sir. Done. Now, the last thing which I want you to know here is the next type of malignant cancer. The last malignant cancer, sir. Renal cell carcinoma is the malignant cancer. Okay. See, what are the benign tumors that we have discussed? Two benign tumors: angiomyolipoma. Second one, oncocytoma. Angiomyolipoma, oncocytoma are the benign tumors. What are the malignant tumors that we have discussed? Renal cell carcinoma and its classification, subtypes. Now, this Wilms tumor, which is also called as a nephroblastoma, which is also called as what? Nephroblastoma. Sir, it's the most common malignant tumor in the children, sir. It's the most common malignant tumor in the children. In the entire childhood, the most common malignant tumor is this Wilms tumor. How many types are there, sir? Important MCQ. Types. There are two types. One is sporadic. Okay, sporadic. Sporadic means what? It can occur in anyone. Just like 90% of the cases, sporadic. In anyone it can come. Okay, sporadic. But if sporadic means usually one kidney is going to be affected, unilateral, or it can be familial. It can be familial, sir, or syndromic. Means genetic involvement is there. Familial or syndromic. Which means associated with some syndromes. Familial is 10% of the cases, and in familial variants there will be bilateral cancers of the kidney. Now important. So this Wilms tumor is the most common malignant tumor of the kidney, also called as nephroblastoma. Most common malignant tumor in the kidneys. Two types, sporadic 90% of the cases, or familial 10% of the cases, associated with some syndromes, associated with some syndromes. What's the first syndrome that is associated? The first syndrome is called as a Vagar syndrome. Okay, W-A-G-R. Vagar. Now you can ask me, what exactly is this Vagar syndrome? See, in this Vagar syndrome, W stands for Wilms tumor. Okay, W is standing for what? The W stands for, right, Wilms tumor. Okay, Wilms tumor means that tumor in the kidney. A for, okay, A for aniridia, no iris. Okay, in this eye you can clearly see, so there is iris in the center, there is a pupil. Okay, that blue color thing is iris, blue color iris is there, in the center there is a pupil. But in this eye, there is no iris. Aniridia, here also there is no iris. Okay, it's just a gap. Okay, so A for aniridia. Okay, aniridia is going to be seen. And what is this G stands for? So here the G stands for the genital anomalies. Genital. Oh. And last one, R stands for mental retardation. The R stands for mental retardation, MR. The patient is going to have MR. So what are the clinical features? The four clinical features which are seen in Vagar syndrome is Wilms tumor, mental retardation, aniridia, and genital anomalies are going to be seen. Okay, genital anomalies are going to be seen. So why all this problem? Sir, it's a syndromic, right? Familial or syndromic, because which means some genes are mutated. Which genes are mutated? WT1. So Wilms tumor, okay, Wilms tumor 1 gene, Wilms tumor 2 gene, WT1 and W2 genes. Okay, the genes which are present on chromosome number 11p, the chromosome number 11p. So this WT1 and WT2 genes which are present on the chromosome number 11p, if they are mutated, that can lead to Vagar syndrome. Okay. Now why I am telling you this? Because in Vagar syndrome, there is Wilms tumor, kidney cancer in the children is going to be seen. Okay. So next familial syndrome, which is called as Beckwith Wiedemann. Okay, Beckwith Wiedemann syndrome. Beckwith Wiedemann syndrome. Sir, what exactly is this Beckwith Wiedemann syndrome? See, the patient is having Beckwith Wiedemann syndrome. One thing is sure, that patient is going to have Wilms tumor. Okay, the patient is going to have Wilms tumor. Apart from Wilms tumor, the patient is going to have organomegaly, big sized organs, organomegaly is going to be seen, macroglossia, big tongue, Wilms tumor in the kidney, organomegaly is going to be seen, macroglossia is going to be seen, also hemihypertrophy. Hemihypertrophy, sir. So what exactly is this hemihypertrophy? Dekho here, Beckwith Wiedemann syndrome, again seen in children. Okay, seen in children, sir. Macroglossia, big tongue. Okay, so there is lateralized growth or hemihypertrophy, which means, see, one side it is going more, the other side is growing less. Dekho here also, one side is growing more, the other side is growing. Beckwith Wiedemann. Why Beckwith Wiedemann? If you ask me, again same WT mutation. Okay, WT2 gene mutation. Okay, the WT2 gene mutations. Okay, I'm not going to in detail about the genetics. There is a concept of imprinting involved over here. I'm not going to here. So the WT gene mutations can lead to Beckwith Wiedemann syndrome, where the patient is going to have Wilms tumor, lateralized growth is going to be seen, or hemihypertrophy with organomegaly and macroglossia. Macroglossia is going to be. Okay. And apart from this, is there anything else which you should know? Yes, there is something like adrenal cortex. Okay, there will be problems with the adrenal cortex also. Adrenal cortex, there will be problem with adrenal cortex cytomegaly. Adrenal cortex cytomegaly, so there will be problem with the adrenal cortex also. Next, look here, you can see the Beckwith Wiedemann syndrome. The patient is going to have these symptoms. Anyway, you can know it. Okay. Now, apart from this, Add one more slide. Sir, is there any other condition which is associated with the Wilms tumor? One condition which is associated with the Wilms tumor is Vagar syndrome. The second condition which is associated with the Wilms tumor is Beckwith-Wiedemann syndrome. And the third condition, the last condition, which is associated with the Wilms tumor in the children is dense. Okay, it's a dense. Is dense, D-E-N-Y-S, dense rash. Okay, sir, dense rash syndrome. Okay, dense rash syndrome. So these patients, the dense rash syndrome, the patient is going to have Wilms tumor. One thing is common, everywhere one thing is common, Wilms tumor is going to be there. Along with that, these patients are going to have gonadal dysgenesis not formed. Gonadal dysgenesis, this is MCQ. Dense rash syndrome, there is gonadal dysgenesis. Wilms tumor is there, gonadal dysgenesis is there. Also, these patients are going to have like kidney problems, like early onset nephropathy. Not going in detail, just simple. One thing which you need to know for your exam is Wilms tumor are associated with which condition? Dense rash syndrome. What is the problem, sir? What is the gene mutation here? WT1 gene mutation. Again, WT1 gene mutation. Okay, so dense rash syndrome is associated with the WT1 gene mutation. Beckwith-Wiedemann is associated with the WT2 gene mutation. Sir, Vagar. Okay, WAGR is associated with both WT1 and WT2. Both. Okay, so there are three syndromic conditions which can cause Wilms tumor in the children, the malignant tumor in the children, the most common malignant tumor in the children, the Wilms tumor. What are the three conditions? Vagar syndrome, Beckwith-Wiedemann syndrome, and Denny rash. Now my question to you, which condition is associated with organomegaly? Beckwith-Wiedemann. Which condition is associated with hemihypertrophy? Beckwith-Wiedemann. Which condition is associated with gonadal dysgenesis? Denny rash. Which condition is associated with aniridia? Vagar, WAGR, Vagar syndrome. Okay, so this is how the questions can be asked in your exam. But at the end of the day, the last important point, the last important point, see, when you look at this Wilms tumor, the biopsy. Okay, when you look at the biopsy, the tumor is made up of what? Okay, it's a triphasic tumor, sir. It's a triphasic tumor. What does I mean by triphasic tumor? Sir, this tumor consists of three types of components. Three types of components are going to be seen in this tumor, sir. What are the three types of components? There will be blastomal components. I will show you also. The blastomal components are going to be seen. Okay, they are the tumor cells, blue color tumor cells. Will show. Okay, and they'll be having epithelial components, epithelial cells. Epithelial component is going to be seen. Also the stromal components. So there are three types of components in the tumor. For example, if you look here, there will be a blastomal component. Okay, there will be epithelial component and the mesenchymal component. Mesenchymal component is nothing but the stromal component. Okay, so there are three types of tissue present in that one single. Three type of tumor. That's why it's a triphasic tumor. Important MCQ, triphasic tumor. You can look here. The blastema is going to be there. Epithelial cells, tubules, the renal tubules are going to be there, and the stroma. Okay, there's a mesenchymal component. It's a triphasic tumor. Three types of tissues are going to be present in the here also. Epithelial cells, there's the tubules, stroma, and blastomal component. Three types of components are seen in one single type of tumor. So it's an example of triphasic tumor. Okay, triphasic tumor. Okay, so these are some important points which I want you to know. So with this, all the important tumors also complete. The malignant tumors, the two malignant tumors, the renal cell carcinoma and its subtypes, and the Wilms tumor. Okay, that's the nephroblastoma which is seen in the children. The two types are also completed. The two types of malignant tumors and the two types of benign tumors. The benign tumors are what? The benign tumors are oncocytoma and angiomyolipoma. The two types of benign and two types of malignant tumors are completed. With this, all the tumors are. Also, we have discussed about the renal tubular necrosis. Also, we have discussed about the renal papillary necrosis and nephrolithiasis. Guys, with this, the renal pathology topic is completed. Tomorrow's class will start with the new pathology topic. Okay, from tomorrow we can start with the new pathology. The class is helpful. Right, thank you.